Hi everybody, thanks so much for watching this video. My name is Dr. Sean Segrin and I'm an emergency physician working in Ontario. Today I want to talk to you about status epilepticus. I want to talk to you about what it means and how to treat it, as well as other things that we may be missing when we think of status epilepticus. So just to define what status epilepticus is, there are really two definitions that encompass status epilepticus. The first one is any seizure that it lasts more than 5 minutes is technically considered to be status epilepticus. And the second definition is a seizure that happens back-to-back, so 2 back-to-back seizures or more with no significant return to baseline in between. And by return to baseline, what is really meant by that is there's still kind of a post-ictal state going on. So the patient still is post-ictal, there's still some confusion, there's no absolute recovery in between. Yes, those are great definitions, not too difficult to remember, but from a practical standpoint, when the patient is standing in front of you, or I should say laying in front of you, having tonic-clonic seizure, it's not something that you're particularly likely going to remember. So from a more practical standpoint, if the patient is still seizing when they arrive with EMS or with paramedics, that is probably status. It's going to take EMS more than 5 minutes to bring that patient here, and even if that seizure did stop in between and they're seizing again, there was probably not much of a recovery period in between. So let's kind of define it as that from a practical standpoint. So if the patient's still seizing with EMS, you're probably dealing with status epilepticus. Why does all of this or any of this really matter? So status epilepticus, as you've kind of determined by now, really is trying to define a seizure that is long lasting, that there's no significant recovery in the brain in between seizures, or there's no significant recovery in the brain because the seizure is ongoing. Why does it matter? It matters because it is more difficult to break when the seizure lasts longer with our typical medications. It can cause permanent brain damage. So as the neurons continue to fire during seizure, that can cause permanent brain or neurologic damage. It can also lead to apnea and other various hemodynamic instability issues. So we really want to be aggressive in our approach to treating status epilepticus. I want to start with a bit of a case and kind of frame the treatment and management of this condition around a case, because I always find that's probably easier for everybody to understand. So let's take a case of a 35-year-old patient. He has a known history of epilepsy, never really been in status before, never been admitted to the ICU. He's on phenytoin at baseline, but we don't know how long he's been taking it for, or if he's actually, taken it regularly. EMS is bringing him in and actually rolls into the emergency department, and he's still seizing. EMS tells you in the emergency department that this patient has been seizing for at least 5 to 10 minutes. So right there it's likely status epilepticus. So you get the patient on monitors, or at least you try to. This is very difficult given the fact that this patient is having tonic-clonic activity. But let's say that you get the patient on some monitors and you see that the pressure is 190/70, maybe accurate, maybe not be accurate. Temperature is 38. That could just be from thermogenesis, from the patient actively seizing, or it could be something else like an infection. So something that we need to keep in mind. In addition, the patient's heart rate is about 160 or so, but again, there's a lot of artifact on the monitor. The oxygen saturation is anywhere between 80 to 100%, and it's not a great waveform because the patient, again, is seizing. You are not really able to attain much of a respiratory rate, especially given the fact the patient is still seizing, and you get a blood glucose. The blood glucose is 5. Let's just pause there. Blood glucose is a must-do in any seizing patient. No matter the age, always check the blood glucose. Refractory status epilepticus, which we'll get to later, one of the causes of it is blood glucose issues, hypoglycemia in particular. So we get the patient on the monitors, and unfortunately there's no IV on the patient. So you decide that you want to give the patient something to try to stop the seizure. So first line treatment is going to be benzodiazepines. You can provide a benzodiazepine in one of two ways. So you can either give it intramuscularly, you can give it intranasally, but in adults we're typically going intramuscularly, or we're going to give something IV. So And an intramuscular benzodiazepine would include midazolam. So you'd give 10 milligrams of intramuscular midazolam if there's no IV. If there is an IV, then you can give 4 milligrams of lorazepam IV. They both work pretty much the same. They work very quickly, usually within a minute or two. So if there's no improvement or no response in the seizure, then it's unlikely that your medication was effective or is going to be effective. You can repeat that dose if you feel it's worth another shot, but in most cases, that second dose probably isn't going to do a whole lot. So that brings us to the second treatment plan for these patients. So number 2 step is going to be to get your anti-epileptic medications primed and ready to go. This is not something that's going to act immediately. So this is something that's going to take some time to prepare, to infuse, and then to actually work. So the medication of choice typically these days is Keppra or levetiracetam, 40 to 60 milligrams per kilogram over about a 20 to 30 minute bolus. So Keppra is a great drug. It has very little side effects. However, it's not something that you would want to use if the patient is already taking it and is known to be compliant. Phenytoin is another medication that can be used, otherwise known as Dilantin, 20 milligrams per kilogram over 20 to 30 minutes. There's some side effects with phenytoin, namely being hypotension. It's also a sodium channel blocker, so beware of that medication, particularly in someone where you're not sure if they may have overdosed on polysubstances or other medications. We're going to mix up those medications, we're going to hang them, and we're going to infuse them. Again, it's going to take some time for the medications to get in, about 20 to 30 minutes. While we are getting that ready and someone is preparing those drugs, we're also going to be preparing our rapid sequence intubation medications. We're not intubating this patient because an endotracheal tube is going to help save their life or stop the seizure. We're intubating them because of the strong sedation medications we're about to give them. And because of those strong sedation medications, they're likely going to go apneic. So the medications that we're going to use to induce the patient can vary. Most people are going to go to propofol. The reason for propofol, and this is a great choice, is because it is a GABA agonist. So GABA receptors actually inhibit seizure activity. So in a status epilepticus or a seizure patient, these receptors are going to be not as stimulated. So we really do want to stimulate them. We want to activate them. So benzodiazepines do this, but propofol is also a very potent GABA agonist. So propofol is a great medication to use. If propofol is not used, ketamine is also a reasonable choice. As the seizure continues, GABA receptors actually downregulate and NMDA receptors upregulate, which can also have some inhibitory properties as far as seizures goes. Ketamine is an NMDA agonist, So ketamine or propofol, very reasonable choices. As far as a paralytic goes, this is where quite a lot of debate usually happens. Rocuronium or succinylcholine. One of them lasts about 45 minutes or so, the other one just a few minutes. Rocuronium is a great choice because it provides the best look at the airway. It will provide you with your first best chance of success in intubating a patient. We know this from multiple studies throughout the literature. So rocuronium can certainly be used. However, the downside to that is it's going to last about 30 to 45 minutes, sometimes more. So during that time of paralysis, you will not be able to neurologically assess your patient nearly as effectively. So you may be missing ongoing seizures while that patient's rocuronium is still working. Succinylcholine does not give you quite as good of a first pass chance of success when it comes to intubation. As well, it can also increase your potassium. So if a patient's been seizing for an extremely prolonged period of time, potassium can increase significantly. You then giving them succinylcholine could potentially even tip them over the edge into a potassium level that is harmful and could cause an arrhythmia. So something to consider. The positive aspect of succinylcholine is the fact that it will last only a few minutes. You can then do a proper neurologic examination after that succinylcholine is worn off. So something to consider. Ultimately, use whatever you're most comfortable with and whatever is going to give you what you feel is going to give you the best chance at intubation, successful and safe intubation. So at this point, we're then going to start some sedation as a infusion. So we can do propofol. Propofol is a great choice to start with. So propofol infusion, if you're still finding that the patient is having some seizure activity, you can increase the propofol infusion, or you can add a midazolam infusion, a ketamine infusion. Multiple options exist. So let's take this case from the start. So what we know is that this young patient has a history of epilepsy, may have or may not have stopped his Dilantin, may or may not have been compliant with it. But what we do know is that he did come in status epilepticus. We tried some midazolam or some lorazepam, IV or IM. Again, IM midazolam 10 milligrams, IV lorazepam 4 milligrams. That unfortunately didn't work, so we started a Keppra infusion that is now running. We have now intubated the patient, and the patient is now on a propofol infusion. So the rocuronium is now worn off. We've optimized multiple drugs, but he's still seizing. Our blood work is still pending. Some things that we need to consider here are causes of refractory status epilepticus. So we've already talked about one of them, and that is blood glucose, so hypoglycemia. So hypoglycemia, if it's not corrected, will result in ongoing and continuous seizures. None of the meds that we give in a typical seizure patient are going to work in this case. The second possibility is hyponatremia, so very low sodium, low enough like 115 to 110 or so, that's going to cause a patient to seize. So this is an acute drop typically, it's not typically chronic. So an acute drop can be caused by many different reasons: acute dehydration, it could be caused from drugs, thiazide diuretics, loop diuretics, etc. Some other potential causes are in endurance athletes where they're running long distances and not replacing their electrolytes properly, so they can have an acute drop in their sodium and then seize. So the treatment for that is going to be 100 cc's of hypertonic saline, that's 3% saline, as a bolus, and then you can repeat that as a bolus if there's no improvement afterwards. Just keep an eye on the sodium and making sure that you're not overcorrecting it. The third and another very important cause of refractory status epilepticus is eclampsia. So, eclampsia is typically seen in later trimesters. So generally speaking, you're likely going to notice that on physical examination, but it's possible that you may not. So always think about that in a young female patient with status epilepticus. Treatment for that is going to be 4 to 6 grams of magnesium sulfate. So to summarize, we've went through an approach to status epilepticus. Remember that status epilepticus is generally going to be anybody who comes into the emergency department with EMS and they are still seizing. But a true definition is a seizure lasting over 5 minutes or two or more seizures with no significant return to baseline in between. We're going to start with high-dose benzodiazepines, and then while we do that, we simultaneously are going to start a anti-epileptic medication like Keppra or phenytoin. We're not waiting for the Keppra and phenytoin to start to work. Instead, we are going to prepare for intubation with RSI medications and then start the patient on a sedation protocol with propofol, midazolam, ketamine, etc. We're going to also always consider causes of seizures from a metabolic and medical perspective. So again, hypoglycemia, hyponatremia, and pregnancy. I hope this was helpful, and I look forward to seeing you all very shortly.